Hello, welcome, and thank you for taking the time to join us. In our presentation today, we will be discussing the emerging need for telehealth amid COVID-19 and innovations in physical therapy education utilizing a simulated learning experience. We are all faculty members at the University of St. Augustine and for Health Sciences, and we represent campuses from across the country, including California, Texas, and Florida.
The didactic aspects of PT course teaching by and large rely on face-to-face interactions to teach and practice patient management skills. Patients can be portrayed by fellow students, faculty, or simulated patients who role play in a manner that mirrors how they would present in practice. Because of the recent pandemic, changes have allowed for increased use of telehealth in healthcare, and there is a growing trend using telehealth in outpatient PT settings as well. PT education has mirrored clinical practice with a shift to virtual environments due to social distancing mandates and infection control. Prior to the pandemic, telehealth simulated learning experiences were not largely utilized within the Doctor of Physical Therapy curriculum at our university. The nation's recent challenges have required changes to teaching approaches and assessment methods via use of virtual learning environments. Adaptations to traditional simulation experiences were made. In a course entitled PCM3, we use simulation learning experiences to augment student learning. These experiences are useful for preparing students for clinical learning experiences and developing professional skills, including communication and critical thinking. This presentation describes the design, implementation, and assessment of case-based PT telehealth performed in PCM3. PT telehealth simulation learning experiences aim to develop student professional skills and clinical reasoning when working with medically complex patients. Course objectives include professional practice behaviors, patient management, clinical reasoning, and communication/patient education.
So in the course PCM3, we created 29 to 62 telehealth simulated learning experiences over the duration of the course, depending on the number of students enrolled. Each student had the opportunity to participate in their own 40 to 45-minute telehealth session with a standardized patient or an actor portraying their patient. The simulation involved a student actor, a standardized patient, and a grader. And immediately after the simulation, the grader hosted a 15 to 20-minute debrief and Q&A with the student PT. The goal of this simulation was to address and improve patient management skills of complex patients in the outpatient setting. For a frame of reference, here are two examples of cases that were used. One standardized patient played a 73-year-old female with osteoporosis, a recent compression fracture, urinary incontinence, and a few other complicating factors. Another standardized patient played the role of a patient that was seeking therapy for peripheral neuropathy and chronic pain, secondary to diabetes, and an undiagnosed foot wound. Here's a quick video clip to demonstrate a gait analysis that was performed by one of our students during their simulation.
You can go ahead and move all that to the side. And once you get here, yeah, you can go ahead and turn around and then just go ahead and walk to that cabinet. Just let me know if you're feeling tired or if your pain's feeling a little bit heightened.
Seems to be okay.
Okay, wonderful. And then you can go ahead and walk back to your chair, and I actually want you to grab onto the back side of that chair there. Okay.
The setup for the telehealth simulation was facilitated via coordination with the Simulation Center. Even remotely, the University Simulation Center was available to locate appropriate standardized patients. In certain situations, the simulation tech dropped off a blood pressure cuff and an assistive device to the home of the standardized patient to be utilized during the telehealth simulation. Standardized patient preparation was performed by faculty remotely to discuss the case and ensure the standardized patient would be safe to perform certain components of the assessment, such as balance and mobility activities during the simulation. The use of the standardized patient allowed more consistency between cases that the students performed. Keep in mind, the simulation tech may also be helpful in training the standardized patient. One important component of preparing the standardized patient was to scan the room and the environment the standardized patient would use during the simulation to determine if it was appropriate. Did it have a clear area for gait, furniture to allow transfers or position changes? An appropriate digital platform is vital to the success of the simulated telehealth assessment. We chose to use a platform available through the university, but as you can see, there are many available. It is always a good plan to do a trial run with a standardized patient to ensure he or she can appropriately interact during the simulated telehealth experience. Prior to the simulation, student preparation is key, as students need to practice the way they will be expected to perform. Pre-brief activities included reviewing online asynchronous presentations and resources, in-class faculty review of the case, including pathology, case information, and evaluation, re-evaluation forms. In some situations, we could view recordings of previous simulations. As time permitted, students were able to perform some skills during class, which allowed faculty and peer feedback to identify areas of growth and strengths. Students were notified of the specific case approximately 48 hours in advance of the telehealth simulation. The telehealth simulation lasted for approximately 45 minutes. The students completed the telehealth assessment of the standardized patient remotely with faculty observing live. The suggested timeline was 15 minutes for a subjective exam, another 15 minutes for performance of the objective examination and virtual test of measurements. Keep in mind that modifications may be required in the digital environment. And then the last 50 minutes providing discussion of treatment and patient education and the plan of care. After the simulation, the students, as you heard earlier, were debriefed by the faculty who performed their grading. The student was provided a video of their performance to assist with completion of a written self-assessment and further skill development.
Now, for the purposes of assessment of this simulation, we utilized the simulated grading rubric, and this instrument included 6 categories, which included safety, professional behavior, communication, clinical reasoning, examination, and educational intervention. And if you notice, for each category, there are between 4 to 8 criteria within each category, and each category was scored at 20 points each. So total scoring for this was 120 points. For the telehealth practical, the students were then required to do a self-reflection to identify their thoughts on performance and learning moments that occurred over the practical session. These were later used by faculty as qualitatively to identify students' thoughts on the practical. This information was graded as a complete or incomplete for the purposes of the course. And here's an example of the initial grading rubric that was used during the practical. And then faculty feedback and comments were taken during the telehealth session and then later used as formative feedback. And on the next slide, you will see the entire grading rubric and including all of the criterion that go along with it.
When looking at student performance and the trends that were seen, there were 3 areas that stood out. Number 1, student grade averages for the telehealth version of their practicals were similar in comparison to prior in-person testing. Considering that we graded their practical performances using the same traditional metric system, this lets us know that by switching to a virtual environment, we were able to structure the experience in a way that didn't compromise their ability to learn. Number 2, we found that students were still able to demonstrate and be graded on their ability to demonstrate their assigned objectives of this course. And number 3, many PT settings were just starting to incorporate telehealth into their practice without any advanced measures at the time. Students were able to get exposure to the differences in communication and patient management skills in the virtual setting in advance of their practice in the field during their clinical rotations. So prior to COVID, in-person practicals worked well since they were mirroring what students would soon be exposed to. With the onset of COVID, our ability to quickly transition to a telehealth platform allowed us to prepare students for what is now current practice. The common themes concerning student feedback on their overall opinions of these experiences were that the use of standardized patients made the experience more realistic and put students in the mindset of being in a real-life patient-therapist treatment session. And because this seemed realistic, it boosted many students' confidence concerning their ability to perform well in their upcoming clinical rotations. Students felt as though this experience allowed them to see their skills through a lens that highlighted areas of needed improvement. So although student skill testing is traditionally done in an in-person simulated clinical environment, test scores combined with student feedback show that our virtual simulated learning experiences were useful for student clinical preparation and highlights the effectiveness of using different learning environments to train our students in emerging areas of PT practice.
In closing, we want to emphasize that simulated learning experiences can be a useful tool in multiple environments, including virtually. And we must recognize as educators that with recent challenges to the healthcare delivery model, telehealth physical therapy is being utilized more often in clinical practice and possibly more often from here on out. Thus, in order to best prepare our students for the clinical role in which they are about to enter, adapting our educational delivery methods to reflect the current healthcare environment can be very beneficial. Thank you for viewing this presentation, and please contact me if you have any questions.